Hello, and thank you for joining me. My name is Robin Noyce, and I'm a Master's of Medical Studies student at NHRC University. Today I'll be presenting our study titled Impact of Adding Slow-Release Oral Morphine During Methadone Induction on Patient Retention, a retrospective cohort study. This research is being conducted in collaboration with Doctors Kristen Morin, Mark Tatangelo, and David C. Marsh. Before diving into the study, I'll disclose my affiliations and sources of support. In 2023, I served as sub-lead in Substance Use Health on Team Primary Care as part of the Training for Transformation Initiative, a $45 million federal project led by the College of Physicians, of Family Physicians of Canada, and the Canadian Health Workforce Network, with over 100 collaborators across the country. This project has received financial support from the Northern Ontario Academic Medicine Association through an educational grant. No supporting organization develops, licenses, or benefits from the sale of any product mentioned here, and I have no financial conflicts of interest to declare. The background of this work is the ongoing opioid crisis in Ontario. With fentanyl now dominating the unregulated drug supply, we've seen a rise in overdose deaths, emergency department visits, and challenges retaining patients in opioid agonist therapy. Although methadone remains a first-line treatment for opioid use disorder, many patients using fentanyl have high tolerance and delayed stabilization, leading to early dropout. An example, Figure 1 shows the probability of patients remaining in treatment over time, with the curve illustrating the retention declines most steeply during the first 30 days, the critical induction period this study focuses on improving. Some clinicians have started co-prescribing slow-release oral morphine during methadone induction to help retain patients in care. But this strategy hasn't yet been rigorously evaluated in real-world settings. The study uses a retrospective cohort design drawing on linked administrative health data from the Institute for Clinical Evaluative Sciences. These data sets include information on prescriptions, physician billings, hospital admissions, emergency department visits, and demographics for all residents of Ontario. We included adults diagnosed with opioid use disorder who began methadone-based opioid agonist treatment between 2014 and 2022. We compared two groups: those received methadone alone and those who received methadone plus slow-release oral morphine during the first 30 days of treatment, a period known as the induction phase. Our primary outcome was treatment retention, defined as the time until a gap of 6 or more days in dispensed opioid agonist therapy medications. Secondary outcomes include all-cause mortality and hospital or emergency visits related to mental health or substance use, excluding alcohol and cannabis. We used multivariable regression models including Cox proportional hazards, logistic regression, and negative binomial regression to control for demographics and clinical variables such as age, sex, housing status, mental illness, and geographic location. The study is currently in the data curation phase of our project, with analysis phase planned for June and July of 2025. Preliminary findings for over 2.4 million opioid agonist treatment episodes show that only 8,651 individuals, or 0.35%, received slow-release oral morphine from this population cohort. Of these, 15% were from Northern Ontario, and all initiated treatment after 2021. This subgroup showed high social and clinical complexity. 55% were reportedly unhoused, and 3% had diagnoses of HIV. Our findings aim to support safer opioid agonist therapy induction strategies, inform clinical practice guidelines, and highlight regional disparities to improve care access in underserved areas. Thank you for listening. We look forward to sharing full results once analysis is complete, and hope this research will support improved care for people with opioid use disorder in Ontario and beyond.